Sanu and Davis, thank you for having us here and congratulations on your first particular workshop. Dr. Paul Abraham for helping out with the AOI Association. And it's always good to be, feels good, although we talk many times across different places. It feels very good when you're talking at memorable events, when you are doing something for the first time like Sanu and Davis have done. And that gives us, no, you haven't removed the presenter mode. I need to remove this presenter mode. As simple as I possibly can, because tongue bass is not something that we are all fond of doing at all. And I don't want to give you all a scare. And it's something that mic is not proper. Is that better now? Okay. See, Srinivas is very tall, so he needed it much higher and I don't. So, the whole idea of trying to give you this from the nose to the palate to the tongue is to get you interested in the field of sleep apnea without actually getting scared about it, right? So tongue is a difficult part to actually handle, but not something that you should shy away from. So what I'm going to try to do is try to tell you about how you should at least start looking at the tongue, how you should be actually looking into doing things, and without any conflict of interest, and it's strictly within the NMC new guidelines that my presentation is going to be with, and thank you for the local hospitality and everything that goes along with it. So why tongue bass? I was not the first person who started OSA work, right? When I was studying MBBS in 85, 86, people were doing OSA work. And the seniors were doing UP3, that was the workhorse, and all of their patients were doing well. They were not satisfied. The patients were satisfied, those seniors were satisfied, everything was going fine. Until, like what Srinivas elaborated on the AHI concept, which was brought in by Sher et al. And here was a bunch of physicians sitting somewhere drawing out guidelines, and a bunch of physicians telling a bunch of surgeons, okay, listen, you're doing UP3, but according to us, it's not helping you. So, that's where we started thinking of tongue bass. That's where we started thinking, why are these surgeries failing? Because probably they instigated us to think more as to what is happening, and that got the concept of OSA a little bit more advanced by just not looking at the palate alone as snoring, but other things. And then they came out with all this data, and we as surgeons, always wanting to prove to our physician colleagues how good we are, we started thinking into it deeper, and that's how tongue bass became a major important part of OSA. So you can see the statistics, it's all out there for you. Without hypopharyngeal obstruction, you had 40.7% success, but with that, your success dropped to only 5.3, and they proved that over a period of time. They presented a lot of data to show that it was just not oropharyngeal, but it was oropharyngeal and hypopharyngeal both combined. And it was a lot of percentage with each different person bringing out different data across the globe. So again, like Srinivas also mentioned, when you have multiple procedures, you don't know which one is really working. You have to work towards one. So with the tongue bass, it's the similar situation. You have external procedures which are not intraoral, and then you have intraoral procedures. So I'm going to give you an overview and try to make you understand how this works. So you have the external procedures which are related to the bony box or sometimes related to the soft tissue. And then you have all these other procedures which are done intraorally, which can be much easier to do sometimes. So let's take one by one very briefly and to an understanding that we can start doing, because these are procedures which we as ENT surgeons can definitely do. Now, a Genioglossus Advancement, Dr. Sukhvinder will talk more about it, but I will just give you a simple concept of what it's done. And the concept is this, that you take out the table, a part of the table of the mandible, and you bring it forward, rotate it, and put it back there, right? This is the basic concept. Now, to understand this, you have to have cephalometry, because if you don't have a measurement of your inner and outer table over here, then you don't know how much you're going to be advancing this thing with, and you don't know how much of the posterior airspace you're going to get. So a cephalometry becomes extremely important for you to know the thickness of the mandible. And based on that, then you can take decisions, because if you're not going to get enough posterior airspace over here, then this procedure becomes highly morbid for that patient to be doing, because you're actually cutting bone, getting it out, moving it front, blah blah, etc. So you need to have maxillofacial training also, or involve your maxillofacial people. Although as ENT surgeons we do maxillofacial trauma, so plating and all is not difficult for us. But you must understand one important thing here is bleeding into the base tongue, because as they will mention to you, when you go through the posterior table of the mandible, and over there if you injure something or the muscle bleeds, the bleeding will go and get accumulated right at the base tongue, which will cause further collapse because of the hematoma. So you must have the necessary training to be able to go through the posterior table of the base tongue. Cosmetic issues are not really that much because it doesn't come out too much, but you have to understand the final thing is the amount of advancement that you can get, because that's what decides the risk to the benefit ratio for this particular procedure. Coming to the hyoid, I won't get to this. So the hyoid suspension was shown somewhere back in 1984, where they used to bring up the hyoid and fix it onto the mandible. But then they modified it a little later and took it down and fixed it onto the hyoid, to the thyroid cartilage. So this is the principle. What it did was, you just tried to reduce this space. As a result, the genioglossus got pulled below. So when the genioglossus got pulled, obviously you have that little advantage. So it's a very simple procedure again, which all of us as ENT surgeons can do, because we do thyroids, we do neck surgeries very simply. And if you look at this procedure, it's so simple. So you take a transverse incision, and then you're going to just, because it's quite superficial, you're really not dealing with too many vessels here, you identify the hyoid bone, right? You deskeletonize and identify the hyoid bone. So there's your hyoid bone that you pick up in your Babcocks or your Cockers, whatever you want. Then you start deskeletonizing the thyroid cartilage, only the superior ala. You find the notch, just deskeletonize it around. And what I showed you in the previous picture, there are two sutures on either side. So the sutures go 1 centimeter lateral to the midline and 2 centimeters. So then after you've done that, you take a 10 proline, which has got a very thick needle, and if your thyroid cartilage is not ossified that badly, you can just take the suture through it. So the point of entries, I'll show you in that next slide again. It's 1 centimeter lateral to the midline and 1 centimeter below the margin of the thyroid notch. So you take that suture, and once you take that suture, then the next suture goes below the thyroid bone. And it's as simple as that. So you are then able to get 4 sutures across, which you will not tighten immediately. You will get the 4 sutures across, and then with your assistant, each suture will be tied together symmetrically, so that you don't have a gap or you don't have a misalignment there. Now you see this? So it's 1 centimeter lateral. So you see this is where you have it. So you have it 1 centimeter on the lateral to the midline, and the second suture is 2 centimeter to the midline. Same on either side, and 1 centimeter below the thyroid notch free border. So that's it. 4 simple sutures there, and you tighten them together with your assistant on the other side, so you get symmetry. Again, not many complications, because you can imagine it's such a simple procedure. You're dealing with the neck, superficial part. What can go wrong? You're really not dealing with any vessels. There's no nerves there. It's subcutaneous. But yes, if you don't remove the neck subcutaneous adipose tissue, you can get a turkey neck kind of a thing over there. So make sure that you remove that little bit of tissue from the neck. And if you compare the results, again, evidence-based, that's what happened. Sher et al. Got us thinking about evidence. And if you look at the evidence-based, published way back even in the 2006 by different people across the globe, you will realize that the success results are pretty much similar, pretty much similar. You're ranging anywhere between 20% to 78% with hyoid suspension, whereas you're doing the same with midline glossectomy, which is much more a dangerous procedure. So the loosening of the sutures is the only thing that is a problem with hyoid suspension, because it will loosen sooner or later. And second is, again, just like in the Genioglossus Advancement, when you have measured the amount of advancement, over here the distance between the hyoid and the thyroid cartilage is roughly the distance that you will get. So one of the drawbacks is that any soft tissue procedure, the muscle is going to lose its tensile strength over a period of time. So when it does that, whatever results you've had initially are obviously going to go down a bit over time. But it's a much more easier and simpler and non-morbid way with evidence-based results, with no airway risks and risk factors at all. For a novice ENT surgeon getting into this field, these are procedures which you can definitely do and not shy away from the tongue base. And this is the reason why, because the removal or excision of tongue base obviously is a much more difficult one when you do it with coblation. But if you notice, the number of cases across the world and across the country are not that much, because people are scared. People are not getting into it and were not convinced about the result, because it's a part of a multi-level problem where you're dealing with the soft tissue of the tongue base, which may or may not later on give you that kind of results, because the results are multifactorial and not dependent only on your tongue base excision. And that is the reason why people are hesitant to get into that, and that is the reason why probably it's not a very sought after procedure. And more important than that, it's not your risk taking ability, so the patient's risk taking ability when you counsel them for all of this. So let's see a simpler way of handling the tongue base, the radiofrequency, right? But here again, you have to realize that it has to be a part of a multi-stage procedure or part of a multi-level program. In the sense, when you're doing step by step, you finish nose, you finish palate, you come to tongue base, then go to epiglottis. That's how you're going to be dealing with the entire airway. So you can't use RF tongue base as an isolated procedure. It's either part of the whole multi-level thing, whether you're doing it multi-staged. If you're doing it single stage, like a lot of us and a lot of y'all will face this, because you have medical tourism, people coming in from the Gulf countries, people coming, they don't have too much time. They can't keep coming back to you again and again. So when you are dealing with those kind of people, and you're dealing with a multi-level single stage procedure, understand the words multi-level, everything is a single stage when you're doing it for them. That's where this comes into handy, right? And there are obviously some potential complications, but there are not so much of airway concerns as you would probably have it with the tongue base. But you must monitor this. Now when I made this slide, I had put it as can be done under local or GA, but I strongly do not advocate any procedures under local nowadays. You best have the airway well secure when you want to do any procedures on the tongue base. Now, I won't get into the physiology and the electrical part of the RF, but basically what it does is gives you this much of a lesion that is formed in the soft tissue, and that lesion over a period of time contracts because of the destruction of the cell nucleoli, and the cells start shrinking, and that is how you get the RF to work for you. A tongue-based probe is different from the palate probe and the nose probe that is used, because it has to be very thick. Tongue base is a thick muscle, it's not easy to go inside. So you have to have an angulation which is almost at 45 degree. You have to have thick probes, and you have to have an insulation which does not allow you to go below 1 centimeter. So when you are on the surface of the tongue and just 1 centimeter below, you are in safe zone. You are not going anywhere close to the neurolingual, neurovascular bundle. So that way it becomes extremely safe. You use a very thick different probe for it, and you apply it in 4 or 5 sites per sitting, in the midline and on the sides. Now there's also lateral insertions and lateral channeling that is done, which has become more popular and more easier to do as compared to the midline ones. So you go in the center, ablate, and just leave it for 2 or 3 weeks to see the difference. So again, see how easy and simple this would be to do. So if you see, the palette has been done here. So this is a part of a multi-level single stage procedure where you use a unipolar probe and you're going in the midline and all you're doing is just inside. So you made sure that you've cleaned everything with betadine. Tongue has to be very thoroughly clean. Rub and rub with betadine, clean it with saline, then insert, and you'll be able to see the fasciculations also very easily. So you have it there. You can put it in 2 or 3 insertions about 1 centimeter or 0.5 centimeters anterior to each other. You can see the fasciculations happening, and that will help the whole tongue to shrink. Now the best part is you need not leave it right at this. Okay, sorry. Here is the other part. You can actually do insertions onto the lateral part of the tongue also. Now this is very simple. You use the same kind of a RF channeling probe and you insert it angulated towards the posterior part of the tongue in this angulation. And the thing here to remember is you see the mucocutaneous junction of the tongue. And as long as you remain at the mucocutaneous junction of the tongue, again you are very safe from the neurovascular bundle. So the dangers of handling the tongue base were basically the lingual artery and the nerves. If you can stay away from that very safely, there is no reason to fear the tongue, and that's how easy it is to tame the tongue. So you can do insertions on the lateral border, 1, 2, 3, and then similarly 1, 2, 3 on either side. When you do this, it's a matter of a few minutes, and you're able to then, and if you notice, you're just at the mucocutaneous junction, see the fasciculations that happen everywhere. So it's not at all a difficult process to do as compared to the actual excision of the tongue base. Now what you need to understand is the considerations of whom you will select for RF tongue base. So the basic issues will remain the same. You will have to look at the BMI, you will have to look at the sleep study, you will have to do either a DICE or an MRI to figure out that the tongue base is at fault. And once you decide that, then like I told you, you use it, but never as an isolated procedure, and especially never as an isolated procedure for the upper tongue base, not so much as for the lower tongue base. And you can very well document your results. So you see the lesion with the RF tongue base, you see the lesion with the RF palate, and you are able to note evidence-based with measurements how much opening that you can actually achieve in all of this. And again, because people got into us about evidence-based work, we always do evidence-based. We don't talk like 25, 30 years back where in my hands this works well, in my this it works well. No, today is the date of evidence-based medicine. You can't stand on any platform, be it national or international, and say this works for me. You either prove it, otherwise they say we don't care who the hell you are and from which part of the world you are. So a tongue volume reduction on MRI has shown to be giving results of almost 17% with an improvement in the posterior airspace by 15% with your speech and swallowing unaffected. And it is almost a 28-month follow-up. So it's not like something which is 6 months or 8 months down the line. But the same thing when you're doing for an excision tongue base, which I'm not going to get into details, but I'll give you an idea of how you need to select that. The selection criteria will remain the same. You've got to identify that there's a tongue base issue. You've got to do the sleep study. You've got to do the DICE, look at the BMI, do a dynamic MRI. But this procedure is generally as an isolated procedure because you're actually going to remove the chunk of the entire thing. But you cannot and you should not practice this procedure unless you have HDU backup, you have ICU backup, or you have people who can handle airway issues at the drop of a hat. Because here there's not going to be much time for you to really look into the airway, because just to enter the airway, you have worked in an area where the anesthetist has to go past that area to enter the airway. So anything and everything that you do there can be very catastrophic. So you must have a good team and make sure that you work only with a good team on this. But we don't really have that much evidence based on the same points like I mentioned about RF. We really don't know how much can be removed, how much every tongue base excision removes how much tissue, And then based on that, we will be able to really judge the results between the two. And of course, needless to say, speech and swallowing is very severely affected in all of this. Now, if you look at some of the data and literature out there, it obviously shows that an excision tongue base is way better than an RF10 base. There's no doubt about that, because you're removing physical mass of tongue tissue. But how do you do it in a situation where you're in a setup where you're starting off? People around you are not so well aware, like in today, and the purpose that we have come here for is to get you to understand what OSA is all about. So it's okay for a tertiary center like what we work in, or in a bigger place what we work in. But in your kind of a setup, you cannot say, I don't have that, so I will not deal with the tongue base and I will leave it alone. You have to make a start somewhere. Keep your aim there. But at least these are procedures which I'm showing you, which are very easy for any ENT surgeon to do without dangers of getting into the problems that we face. We don't have Indian data, unfortunately. The data that I showed you was all related to the Western world. Now, this is where we want people to get into the field. We want people to collect data. We want people to be more enthusiastic about a situation which has been shown to you that the Indian population has 35% incidence. That's huge. That's really huge. It's more than, 1 in 4. It's actually 2 or 2.5 in 4 or 5 patients. So once you decide that you have had a tongue-based issue, these are the questions that should go through your mind. How am I going to tackle it? Am I going to tackle it as part of a single stage multi-level procedure? Or am I going to do it multi-stage where I will tackle tongue base as one part of it? These are the questions you have to start answering, and then you can come to your decision making. So if you decide that you're going to do it as a part of a single stage multi-level procedure, then you should be asking yourself these questions. What am I doing to the nose? Am I going to be actually packing the nose or not? Now these are questions we used to ask ourselves maybe 10 years back. I think today we don't even need to ask these questions, because none of us, I presume that even here you do the same, none of us pack the nose after nasal surgery most of the times. If it's like a septal surgery or whatever, you're either doing a quilting suture or you're keeping a splint. And Sanu showed you that one paper where blocking the nose worsens your apnea. So you keep the nose open most of the times nowadays. You take quilting sutures or you do nasal splints. Second thing you should ask yourself is, how aggressive is that palate surgery that I'm going to do? Is it reconstructive or is it a somnoplasty? If it's a reconstructive one where you're doing a lot of stuff, then you need to be more careful. If it's just a simple somnoplasty, you don't have much to worry about. Post-op backup, you need to ask yourself where you stand. And at the end of it all also comes the fact that you need to ask your patient whether are they okay for it. I may feel very confident as an ENT surgeon. I may be the best surgeon around, but if my patient doesn't want that happening, this is a situation where his wants and wishes are to be taken into account when you're treating them. You cannot dictate to the patient that this is what you can advise them, give them the pros and cons, give them the counseling, give them options, and then go ahead and do what you have to do. And if you're doing it as a single level stage in a multi-stage scenario, then the only question that you need to be asking yourself is, what procedure am I going to use? Am I going to be using a channeling, or am I going to be using an excisional procedure? And then you check about the post-op backup that you have and then take it forward. So here's a rough way that you can think of deciding what procedures to do. These are based on the Moore's classification, which all of you all can just read up in the books. So if you have a high dorsum, you can either do an RF or a genial advancement along with a coblation or with a coblation excision. But you have a high dorsum plus low dorsum and a retroepiglottic narrowing, then it is best done by dealing with it intraorally with excision and also externally with a hyoid suspension. So you mix both the procedures, or you combine both the procedures to do it. And of course, if you have purely a retroepiglottic, then you're not going to achieve much with the tongue base. You can just do whatever you need as a hyoid suspension, which is simple, and tackle the epiglottis as is going to be spoken in the next talk. So there are a bit of not so very good things with the RF. So it's minimally invasive. So you can't expect miracles out of a minimally invasive procedure. So the size of the lesion achieved is small. So your counseling and your waiting for the next 3 to 4 weeks becomes extremely important to see the results before you get forward. And you must talk about a repeat of the procedure if needed. Because it's not necessarily that open is all glamour. And if you can't do the greater things in a bigger way, at least do the smaller things in a smaller way so that you can start helping your patients and not just leaving them off to a CPAP. Sometimes excision of tongue base doesn't really give you that kind of a required result. So here's a case which I had done long time back, I'm not very fond of, but I looked at it and that was a tongue base, primary, pressing onto the epiglottis, right? This is what happened on day 2. The epiglottis didn't move at all. And this is what happened on day 7, epiglottis didn't move at all. So I was wrong and I went ahead and did something. So you need to be a little bit more careful. So the broad considerations when you decide on a tongue base will remain the same. If it's a multi-level single stage procedure with minimum tongue base involvement, stick to the RF. If it's a multi-level single stage procedure with a major tongue base involvement, stick to excisions but consider all the points that I mentioned to you. If you've already done the nose and the palate and it's a single level procedure with a major tongue base involvement, then you either make sure you're excising the tissue or then you make sure you're entering it intraorally as well as externally. So if you're not excising it, go ahead and do an RF and do a hyoid suspension combined together. So this is how you make those decisions, because in private practice, you have to make sure that you have everything, including, most importantly, an honest assessment of your own surgical training before you venture into any of this. You have to do it for yourself, not for anything else. And you have to look at the patient profile. Is that patient really going to be willing to take all this from me or not? So assess yourself very honestly before you venture into any kind of surgical work. The tongue-based future is yet to come. It's almost reaching India very soon, hopefully this year, but for the past 20 years it has not come. We've been having hypoglossal implants a lot and it's got good value, except for obviously the cost factors, but we will not comment on that in India as yet because none has been done as yet. But what you can do in India, and which definitely a lot of people in Kerala can do because a lot of them are loaded with money, is you can put them in a spaceship and send them to Mars where there's zero gravity, so there will be no OSA. And that's 100% treatment which you can guarantee to that patient there. So what I would just like to leave you with thinking is do whatever you can wherever you are, because as you get in depth about all of this, there is a lot we realize that we don't know. We thought we knew a lot, but as you grow into the field, you'll realize that. And the one message that I would really like to give every one of you all entering into the field is PSR is more important than PSR. PSR, according to me, I label it as your patient satisfaction rate is way more important than your peer satisfaction rate. Do not bother about what your peers talk to you or talk about you. Your focus should be on your patient satisfaction rate. So with the proper counseling and giving them what you have honestly, you can counsel them and say, listen, I'm not going to be able to do this. You want to do this kind of tongue base here? Yes, there are people in India who are doing this. You are more than welcome to go there. But if not, this is what we can do and this is what we can expect. Because they will be the ones who will be responsible for all your practice in the future. So thank you very much, and I hope that taming the tongue is very difficult, especially when you're in Kerala and using the Kerala cuisine. I don't want to tame my tongue, I want to let it loose. But at least over here in OSA, you can try and tame the tongue this way. Thank you so much.